Welcome to Healthcare UK, your trusted source for clear, evidence-based health insights from the front line of UK healthcare. I'm Leda, a registered nurse. If you value credible health information, make sure you subscribe and hit the notification bell so you never miss an update.
Question 1. Assessment Station. History and Observations. You enter Mr. Thomas's room for his routine observations. You note his respiratory rate is 26 breaths per minute. Oxygen saturation is 90% on room air. Temperature is 38.5 degrees Celsius, and his blood pressure is 95/60 millimeters of mercury. Question. Calculate the patient's current News 2 score and identify the immediate priority action based on this score.
Answer. News 2 calculation. Respiratory rate 26 per minute, 3. SpO2 90% on room air, not chronic hypercarbonic failure, 3. Temperature 38.5 degrees C, 1. Systolic BP 95 millimeters, 2. Pulse, consciousness, airway, assume 0 unless specified. Total News 2 score 3 + 3 + 1 + 2 = 9. Immediate priority action. Escalation of care. A News 2 score of 9 is a high clinical risk, red zone, score greater than 7. You must immediately alert the medical team, senior nurse, A to E assessment, provide high-flow oxygen, 15L via non-rebreather mask, and initiate necessary interventions as per local protocol. Explication. The National Early Warning Score 2 is a critical tool for identifying acutely unwell patients. A score of greater than 7 indicates a high risk of critical illness and requires an urgent, time-critical response, typically a consultation with a critical care outreach team or senior medical review within minutes. Providing high-flow oxygen is a key initial intervention for hypoxemia. Question 2. Planning Station. Care Plan. Task. Following your assessment, News 2 score 9, the medical team is on its way. You need to document a concise plan of care related to his respiratory function. Question. Write 2 appropriate, measurable, and time-bound outcomes for Mr. Thomas's care and list 3 corresponding interventions you will implement before the doctor arrives. Outcome 1. Outcome 1. Patient's SpO2 will be greater than 94% within 30 minutes of initiating oxygen therapy. Outcome 2. Patient's respiratory rate will be less than 20 breaths per minute within 60 minutes of antibiotic and fluid administration. Intervention 1. Apply 15-litre oxygen via a non-rebreather mask and monitor saturation continuously. Intervention 2. Establish intravenous access, cannula insertion, to prepare for IV fluid and antibiotic administration. Intervention 3. Reposition Mr. Thomas into a semi-recumbent, semi-Fowler's, to aid breathing. Explication. Care planning requires setting SMART, specific, measurable, achievable, relevant, time-bound goals. The interventions focus on immediate stabilization and preparation for the medical team's treatment plan, oxygenation, IV access, and optimal positioning.
Question 3. Implementation. Station. Medication. Task. The medical team has prescribed 500 milligrams of IV paracetamol perfalgan to be administered over 15 minutes. The pharmacy supplies a 100 milliliter bag containing 10 milligrams per milliliter. Question. 1. What is the total dose of paracetamol in the 100 milliliter bag? 2. Calculate the rate, in milliliters per hour, for the infusion pump to deliver the medication over the prescribed 15 minutes.
Answer. 1. Total dose: 100 milliliters times 10 milligrams per milliliter equals 1000 milligrams. 2. Infusion rate in ml per hour. Volume to infuse: 500 milligrams divided by 10 milligrams per milliliter equals 50 milliliters. Time in hours: 15 minutes divided by 60 minutes per hour equals 0.25 hours. Rate: 50 milliliters divided by 0.25 hours equals 200 ml per hour. Explication: accurate drug calculations are non-negotiable for patient safety. The prescription is 500 milligrams, so only half the bag, 50 milliliters, is required. The calculation must convert the time into hours for the infusion pump setting.
Question 4. Evaluation station. Handover. Task: you need to give an urgent handover to the covering nurse before your break. Mr. Thomas is now stable with SpO2 95% on 4 litres nasal prongs. Question: structure your handover for Mr. Thomas using the SBAR framework: situation, background, assessment, recommendation.
Situation: I am calling about Mr. Thomas, 68, with pneumonia. He had an acute deterioration an hour ago with a News 2 score of 9, but is now stable. Background: admitted 2 days ago for community-acquired pneumonia. He has a history of COPD, mild. He had a spike in temperature to 38.5 degrees Celsius, which triggered the drop in oxygen saturation and blood pressure. Assessment: he is currently stable. Vitals are RR20, SpO2 95% on 4 litre nasal prongs, BP 115/70 millimeters of mercury, temp 38.0 degrees Celsius. IV paracetamol was given. He has a cannula in his left forearm. Medical team has been notified and prescribed IV antibiotics to start as soon as they arrive on the ward. Recommendation: please monitor his SpO2 and BP closely every 15 minutes for the next hour. Start the IV antibiotics immediately when the doctors bring them up. Continue 4 litre O2 and reassess his News 2 score in 1 hour.
SBAR, situation, background, assessment, recommendation, is the standard structured communication tool used across the NHS to ensure critical information is transferred accurately, consistently, and concisely, especially during urgent handovers. Part 2. Clinical and practical skills. Question 5. Aseptic non-touch technique. Question: list the 4 key stages of the aseptic non-touch technique. Say the following in a British accent. Preparation: gather equipment, hand hygiene, and check the environment. Aseptic field: create a critical and general aseptic field, example, using a sterile drape. Key part, key site protection: protect the key parts of the equipment and the patient's key site, wound or insertion point from contamination. Disposal and documentation: discard waste, hand hygiene, and document the procedure. Explication: ANTT is the UK standard to prevent infection during invasive clinical procedures. Maintaining key part, example cannula tip, and key site, example wound, protection is the central principle. Question 6. Peripheral venous cannula management. Task: a patient's PVC site is red, swollen, and tender. Question: what is the most likely complication and what is your immediate nursing action? Most likely complication: phlebitis, inflammation of the vein. Immediate action. 1. Stop the infusion if running. 2. Remove the cannula immediately. 3. Apply pressure to the site briefly, then a clean dressing and an ice pack if appropriate or prescribed. 4. Document the finding and the action taken. Explication. Signs of phlebitis require prompt removal of the source of irritation, the cannula, to prevent further inflammation and potential infection. Question 7. Hand hygiene. Task. You are about to perform an intravenous drug administration. Question. List the 5 moments for hand hygiene as defined by the World Health Organization, WHO. Answer. 1. Before touching a patient. 2. Before a clean, aseptic procedure. 3. After a body fluid exposure risk. 4. After touching a patient. 5. After touching patient's surroundings. Explication. The WHO 5 Moments framework ensures that hand hygiene is performed at the most critical points of care delivery, protecting both the patient and the healthcare professional. Question 8. Intramuscular (IM) injection site selection. Task. You need to administer a vaccine to an adult patient. Question. What is the preferred IM injection site for routine adult vaccinations, and why is this site preferred? Preferred site. Preferred site, deltoid muscle, upper arm. Reason for preference. It is easily accessible, has sufficient muscle mass in most adults, and is generally associated with a low risk of damage to underlying nerves or blood vessels compared to sites like the dorsogluteal area. Explication. Correct site selection minimizes pain and the risk of complications, e.g., sciatic nerve damage. The deltoid is the most common and safest site for volumes up to 2 milliliters in adults. Question 9. Peak expiratory flow rate, PFR. Task. You are performing a PFR measurement on a 35-year-old patient with new onset asthma. Question. Briefly describe the 3-step process for accurately measuring and recording a patient's peak expiratory flow rate. Answer. 1. Position and preparation. Patient sits upright. The indicator is set to 0. The patient takes a maximal deep breath in. 2. Blow. The patient seals their lips tightly around the mouthpiece and blows out as hard and as fast as possible in a single short burst. 3. Record and repeat. Note the reading. The process is repeated 3 times. The highest of the 3 readings is the one recorded. Explication. The PEFR is a measure of a patient's lung function. Repeating the test 3 times and taking the highest value ensures the best possible effort and an accurate reading, preventing underestimation due to technique. Question 10. Fluid balance chart. Question. A patient's fluid balance chart for your 8-hour shift shows the following. Input: oral fluids 400 ml, IV fluids 500 ml, IV antibiotics 100 ml. Output: urine 650 ml, vomitus 150 ml. Calculate the patient's net fluid balance for the shift and explain its significance. Total input 400 milliliter plus 500 milliliter plus 100 milliliter equals 1000 milliliter. Total output 650 milliliter plus 150 milliliter equals 800 milliliter. Net fluid balance 1000 milliliter minus 800 milliliter equals plus 200 milliliter. Significance. The patient has a positive fluid balance of 200 milliliter for the shift, meaning they have retained 200 milliliters of fluid. This is crucial for managing conditions like heart failure, where a negative balance is desired, or dehydration, where a positive balance is desired. Explication. Accurate fluid balance monitoring is essential for managing a patient's hydration status, especially those with renal, cardiac, or complex fluid issues. Question 11. Blood transfusion. Question. Before commencing a blood transfusion, what 3 critical checks must be performed at the patient's bedside by 2 registered practitioners? Patient identification. Check the patient's identity, name, date of birth, hospital number against their wristband and the compatibility form. Blood unit verification. Check the blood unit number, blood group, expiry date, and inspect the unit for any signs of damage or clots. Compatibility form verification. Check the details on the compatibility form against the unit and the patient's details. Ensure the form is signed and dated. Explication. These double checks are mandated by UK guidelines to prevent the fatal error of transfusing the wrong blood into the wrong patient, wrong blood in tube, wrong blood in patient errors. Question 12. Wound swab technique. Question. Describe the correct technique for taking a wound swab from a pressure ulcer to test for infection, specifying the required area. Technique, Levine's technique. 1. Clean the wound with sterile normal saline to remove surface contamination. 2. Identify a clean area of the wound bed, the deepest area or area showing signs of infection. Rotate the swab over a 1 square centimeter area with sufficient pressure to express fluid from the tissue. 4. Insert the swab into the transport medium and label correctly. Explication. Levine's technique ensures the sample is taken from the actual site of replicating bacteria, not just surface contaminants, leading to a more accurate result. Question 13. Basic life support, BLS, adult. Question. An adult patient collapses on the ward. Outline the correct sequence of chest compressions and rescue breaths to be performed by a single rescuer according to UK Resuscitation Council guidelines. Sequence: 30 chest compressions followed by 2 rescue breaths, 30:2 ratio. Rate: 100 to 120 compressions per minute. Depth: at least 5 centimeters, but no more than 6 centimeters. Explication. The 30:2 ratio is the standard for single rescuer adult CPR, prioritizing high-quality chest compressions with minimal interruptions. Question 14. Safe disposal of sharps. Question. You have just inserted an intravenous cannula. List 3 rules for the safe disposal of the used needle, stylet, and other sharps. Answer. 1. Do not recap the used needle. Immediately dispose of the used sharps into a dedicated sharps container at the point of use. 3. Ensure the sharps container is never overfilled and is closed securely when not in use and upon final disposal. Explication. Sharps injuries are a significant risk. Never recapping and immediate disposal at the point of use are key practices to prevent needle stick injuries. Part 3. Professional Values and Ethics, PV.
Question 15. Accountability, NMC code. Task. A colleague admits to you that they administered a patient's regular medication 4 hours late because they were busy with another emergency and forgot to delegate the task. Question. What is your professional and ethical responsibility as a registered practitioner according to the NMC code? Duty to report. Act. Your professional responsibility is to act in the best interest of the patient and uphold public trust. You must first ensure the patient is safe and not harmed by the delay, documenting the late administration and the reason. Escalation. You have a duty to raise your concerns about your colleague's professional practice with a senior colleague/manager. This is necessary to ensure accountability, prevent future recurrence, and protect patients. Explication. The NMC code, for example, preserves safety and promote professionalism and trust, requires you to take action if a colleague's practice may put patients at risk. This is a matter of professional accountability.
Question 16. Confidentiality and information sharing. Task. A patient's family member, who is not the named next of kin, calls the ward asking for an update on the patient's condition. What is the initial question or action you must take to comply with patient confidentiality guidelines? Initial action. You must first establish if the patient has given explicit consent for information to be shared with this specific individual. Procedure. State that due to confidentiality, you cannot give out any information until the patient has confirmed they are happy for you to do so. You must then check the patient's records for documented consent or ask the patient directly if they have capacity. Explication. Patient information is confidential. Consent must be established for information to be shared, in line with General Data Protection Regulation, GDPR, and the NMC code. Question 17. Capacity and consent. In the context of the Mental Capacity Act 2005, England and Wales, what is the fundamental presumption about a person's capacity? Answer. The fundamental presumption is that every adult has the capacity to make their own decisions unless proven otherwise, i.e., a person is not to be treated as unable to make a decision unless all practicable steps to help them to do so have been taken without success. Explication. This is the first principle of the Mental Capacity Act 2005. It places the burden of proof on the assessor, the clinician, to demonstrate a patient lacks capacity, not the other way round. Question 18. Conflict resolution. Task. A patient is refusing a necessary procedure but has acknowledged the risks. The procedure is non-life-saving. Question. How should you respond to the patient to respect their autonomy while ensuring all professional duties are met? Answer. Respect the patient's decision to refuse treatment, autonomy, provided they have the mental capacity to do so. Action. Document the refusal clearly in the notes, including that the risks were explained and understood. Inform the senior medical/nursing team and the consultant. Continue to provide all other necessary care and support, maintaining a therapeutic relationship. Explication. A mentally competent adult has the right to refuse treatment, even if that refusal may lead to harm. The professional duty shifts from compelling treatment to ensuring the decision is fully informed and documented. Part 4. Evidence-based practice, EBP. Question 19. Role of evidence-based practice. Question. Define evidence-based practice, EBP, in a clinical setting and state its primary goal. Definition. EBP is the process of integrating the best available research evidence with the practitioner's clinical expertise and the patient's values and preferences to make healthcare decisions. Primary goal: to improve the quality, safety, and effectiveness of patient care by ensuring clinical interventions are based on scientifically proven methods. Explication. EBP moves away from tradition-based practice, combining high-quality evidence with individual patient context. Question 20. Critical appraisal, PICO. Question. When critically appraising a research paper, what does the acronym PICO stand for, and how is it used?
P. Patient, population or problem, elderly patients with hip fracture. I. Intervention, example, early mobilization. C. Comparison, example, standard care or late mobilization. And O. Outcome, example, reduced length of hospital stay. Use. PICO is used to formulate a clear, answerable clinical question that can then be searched for in the literature. Explication. PICO is a foundational tool in EBP, turning a clinical problem into a searchable and answerable question. Question 21. Hierarchy of evidence. Rank the following research methodologies from highest to lowest in the traditional hierarchy of evidence: systematic reviews and meta-analysis, case series, case reports, randomized controlled trials, RCTs, expert opinion. 1. Systematic reviews and meta-analyses, highest. 2. Randomized controlled trials, RCTs. 3. Case series, case reports. 4. Expert opinion, lowest. Explication. Systematic reviews, which aggregate multiple RCTs, are considered the highest quality evidence for establishing cause and effect relationships due to their methodological rigor in reducing bias. Part 5. Additional integrated skills. Question 22. Managing sepsis. Task. You suspect a patient with an existing infection has developed sepsis. Sepsis 6 pathway. Question. Name 3 of the 6 core elements of the Sepsis 6 care bundle that must be administered within 1 hour. Any 3 of the following 6 interventions. 1. Take blood cultures. 2. Measure blood lactate and blood gases. 3. Give high-flow oxygen. 4. Give intravenous fluids. 5. Give intravenous broad-spectrum antibiotics. 6. Measure hourly urine output. Explication. The Sepsis 6 is a standardized bundle of time-critical interventions designed to improve outcomes for patients with sepsis. Time is crucial as mortality increases with every hour treatment is delayed. Question 23. Falls prevention. Question. A patient on your ward is assessed as a high risk of falls. List 3 non-pharmacological interventions you would implement to minimize this risk. Environmental modification. Ensure the room is well lit, clutter-free, and bed rails are up or alarm is active as per policy or risk assessment. Aids and equipment. Ensure the patient has their walking aids, example Zimmer frame, and that the bed and chair brakes are on. Toileting or regular rounding. Implement regular and assisted toileting to reduce urgency and unassisted trips to the bathroom, the most common place for falls.
Bonus: footwear. Ensure the patient is wearing well-fitting, non-slip footwear. Explication: falls prevention is a major NHS priority. A multifaceted approach addressing intrinsic factors, patient condition, and extrinsic factors, environment, is necessary. Question 24. Communication. Breaking bad news. Task: you're speaking with a patient who has been diagnosed with a chronic, progressive condition. Name and briefly explain one key communication framework you would use to structure this conversation. Spikes, or ABCDE, or SHARE, is an appropriate framework. Spikes. Setting: prepare the environment, private, quiet room. Perception: ask what the patient already knows or understands. Invitation: ask how much the patient wants to know. Knowledge: deliver the news. Warning shot, then simple, clear information. Emotions: respond to the patient's feelings. For example, I can see this is a shock. Strategy and summary: create a plan and summarize the next steps. Explication: using a structured framework ensures that the conversation is patient-centered, empathetic, and covers all necessary stages, from preparation to planning. Question 25. Drug administration. The rights. List the 5 essential rights, the minimum standard, a nurse must check before administering any medication. Right patient, right drug, right dose, right route, right time. These 5 core rights form the minimum standard for safe medication administration. Modern practice often extends this to 8, 10, or 12 rights. For example, right documentation, right reason, right to refuse. But the core 5 remain the fundamental safety steps.
I hope that deep dive into CBT questions was helpful. If it was, a like would be amazing.